day 727. Who's watching? Well, obviously no one. But anyway, if anyone comes and you've got any questions, ask them. Or if you're watching this on the replay and you've got a question, then ask them and I'll bring it up next week at 7 p.m. ish. Yeah, it's JJ Staiano, plastic surgeon to the stars here. I have got some questions that have already been asked of me, which I'm going to rattle through now. But if anyone does decide to come on and ask me a question, then they really honestly would be more than welcome. So while we're waiting for everyone to arrive, let me just get started, shall we? How long will I need off work after a tummy tuck and why? So the initial question to that is, what do you do? Obviously, is that obvious? Because it kind of depends on what you do. But just talking broadly, the first week you're not going to feel like doing much work at all. After a tummy tuck, it is quite a big op. You'll be bent double. So you won't really fancy going to work, to be honest with you. The second week you will be feeling better and you will be doing kind of like computer things on the computer, but you'll probably be, relaxing for the second week. The dressings come off after the first week, by the way. And you're normally bent over double. I would say 2 weeks is kind of normal. It varies obviously between people, but 2 weeks is normal for you bent over, hunched, and your back hurts. And so so the first 2 weeks is a little bit uncomfortable. I wouldn't, it's you're not going to feel like doing much. After 2 weeks, you can start doing things like, walking. You can do exercise your lower body, like the stepping machine or the cross trainer, not too crazy with your arms, or the bike, the exercise bike, things like that. You don't really want to be doing impact things like running and what have you, but you'll be doing low impact things and walking. Sometimes you're fine to drive at 2 weeks, sometimes 3. So obviously if your work requires driving, then 3 weeks is probably safe. You might be okay to drive after 2. By the way, we will be keeping in touch with you during this time, and we will be guiding you as to how you're getting on, because some people get on really well and recover really quickly, and some people take a bit longer to recover. So these are sort of broad brush strokes, as it were. So yeah, after 2 to 3 weeks, you'll be driving and getting out and about and doing stuff like that. So if your job involves desk-based work, I would say 3 weeks. If you're self-employed, 2 weeks. Sometimes if you tell an employed person 2 weeks and they're not well enough at 2 weeks, the workplace gets annoyed. So 3 weeks is kind of safer. But for self-employed people, they often go back earlier because they can kind of take, go home or whatever if they're feeling a bit uncomfortable. So 2 to 3 weeks for desk-based work. If you are doing something heavy which requires engaging your core, like lifting people or lifting boxes, or I suppose you're not lifting people, are you? Maybe you're lifting children, maybe. But anyway, if you're lifting things, for at least 4, probably 6. So 6 then. Okay, 6 weeks before you're lifting and things. And even then you'll be starting slow and then just building up gradually. So to keep it simple, 3 weeks for light duty, 6 weeks for heavier lifting and what have you. But it does vary on the individual basis, and that's broadly speaking. And even at 6 weeks, you're going to feel a bit uncomfortable when you just started lifting and things like that. Especially if you're doing the gym, start slow, do small kind of weights and things. All right. What will my breasts look like when I take the dressings off following a breast reduction or uplift? Well, I show all my patients photos of what they look like, because they look odd, should we say? I think that's the term I'd use. They look odd, and so I try to stress to people not to be alarmed, because they don't look like how they're going to look like in the end. When you first take the dressings off, they look odd. The way they look odd is there's too much volume in the upper pole, not enough volume in the lower pole. They're very empty in the lower pole. The nipple down is kind of like a straight line instead of a nice curve, and the upper pole is too full, so they're quite full and they feel like they're underneath your chin. Some people might like that, and I always try and say, look, try not to like it too much, because it's going to settle, and it's going to settle from the upper into the lower pole. So the shape does change quite dramatically from the first week to the, I normally say about 3 months for it to start to settle, but 6-7 weeks, I guess, it's kind of starting. but it does take months for it to fully settle that shape. And sometimes one side settles better than the others. So than the others. There's only one other side. Yeah. So sometimes one side settles better than the other. So you have to give it a few months to get yourself an idea of how it's going to look. But just try not to be too alarmed in the first week when the dressings come off, because they always look a little bit out of kilter. Why, when you remove my cyst, do I still have a lump? And do I need to worry? Okay, well, you might not have a lump, but if you do have a lump, no, you don't need to worry, because when you remove a cyst, you leave a space where the cyst was, and often we don't remove a huge amount of skin. If you do remove a lot of skin, you run the risk of getting dog ears, which are little bumps at the end of the scar. So we often don't need to move a lot of skin. Depends on how much the cyst is tenting up the skin. But the point is, when you remove a cyst, there's space. That's the point. There's space underneath the skin where and that space can fill up with fluid, and that can cause a bump that looks like the cyst. So that's the point. So when you remove a cyst, sometimes you get fluid filling in the space where the cyst was, and that can kind of look like the original cyst. So it can be a little bit disconcerting that you have your lump removed, you pay for it, you have a scar, and then a week later you've still got a bump, but you've also got a scar and you've got a hole in your wallet. So again, try and tell people, try not to worry about that, because the bump that you've got a week after is usually swelling. It's not the cyst coming back, it's not some of the cyst being left behind, it's usually swelling. And again, you have to leave it a few months. If at 3 months there's still a lump there or a bump or anything like that, and you need it, if the cyst's not all been removed or there's any issue, then we'll do it for you for no charge. But don't worry if you get a bump at a week, because it's not uncommon to get a bump at a week, and it's usually swelling, which then settles. So don't worry, give it time, and then if it's still there in 3 months, then worry. But don't even worry then, because we'll just fix it. Why do you use removably stick sutures on the face, but dissolvable ones on the body? Well, this I think is a personal thing. I think we're all training's different, and some people do use dissolvable stitches on the body, on the face, but I don't use dissolvable stitches on the face as a rule. I mean, there might be exceptions to that rule, but as a rule, I try not to. And the reason I don't use it on the face is because it causes redness, and because it causes a degree of inflammation while the stitch dissolves. And that means that the scar's not as good if the scar's a bit red and inflamed. So in that respect, a non-dissolvable stitch that is coming out in a week is better. So a non-dissolvable stitch that you can take out in 5 or 6 or 7 days, that stitch is out of your body in 7 days, and there's no stitch material there. There's been no reaction to that stitch while it's been in. So in that respect, a non-dissolvable stitch is better than a dissolvable one in terms of the scar. And on the face, the scar is really important. Now you might say, wait a minute, the scar's really important on the body as well, pal. So I want non-dissolvable stitches on the body. So the reason I tend not to, again, as a rule, there's always exceptions, but I tend not to use non-dissolvable stitches on the body is because the face heals quickly. That's the big difference. So the face will be healed in 5 to 7 days. So you can reliably take those stitches out of 5 to 7 days. The body is a bit slower to heal. The trunk, the arms, the limbs, the legs, the back. So that will take longer to heal. So if you were going to put interrupted non-dissolvable sutures on the body, you might want to leave them 2 or 3 weeks. Now, if you leave them 2 or 3 weeks, you're going to get stitch marks. You're going to get little dots at either end of the scar. So that's why I would tend to bury a dissolvable stitch and accept the fact that it will be a bit more red while it is healing, but you need the stitch to be there longer because the body, the trunk, the arms, legs, back, it takes longer to heal. So you want to leave the stitch longer in the body, and so you don't want to leave stitch marks, which are those little dots on either side. So that's why I use dissolvable ones on the body and non-dissolvable ones that you have to remove, on the face. Personally, as a rule, there may be situations where I break the rule, but that's the rule. That's a good question. Thank you for that. I completely understand that detailed advice requires a consultation. I wanted to ask whether this clinic routinely performs revision gynaecomastia cases and feels confident taking on complex asymmetry and skin excess cases. So this is a patient who's got in touch the other day, and I think they've already seen another surgeon, and the other surgeon said it's too complicated and didn't want to take them on. So now they're a bit anxious, or they don't want to go through that again, which is completely understandable. So they're looking for someone who can help. So in answer to that question, I don't routinely perform revision gynaecomastia cases because I don't tend to operate on other patients' cases, other doctors' cases. So if you have an operation and you're not happy with it, I would tend to say to the patient to go back to their original surgeon, and that would be my advice. And I tend not to get involved with revising other doctors' surgery. Having said that, obviously I do revise my own, so I do perform revision gynaecomastia cases, but I wouldn't say I routinely perform it because I try and avoid the requirement to perform revision gynaecomastia. So I'm not out there looking for complex cases. I'm not looking for revision cases. I am looking for primary cases, people who've not had surgery before who are looking for a gynecomastia correction. So I do feel confident taking on skin excess cases, so involving skin excision. Now the scarring is more obvious with those cases, so that's a discussion that needs to be had there. But it's feels confident taking on complex asymmetry. I mean, I think at the end of the day, you have to kind of look for the qualifications of your surgeon and see if the surgeon's right for you. I mean, gynecomastias are pretty much often, maybe always asymmetrical. But it sounds like you've had a bad result from a case with you're requiring revision to fix that, which is always more difficult. Revision surgery is always more difficult than primary surgery because there's scar tissue there. There's expectations from yourself. So it's always difficult doing revision surgery, and so I try and avoid it if I can. I have to do it on my own patients, but fortunately I don't do it very often because I try not to put myself in a situation where I need to do a revision. But if I do, I will do it. But if you're looking for someone who kind of thrives on doing other patients, other surgeons' revisions, that's not me. I don't thrive on it. I don't routinely perform revision gynecomastia cases. And if you come saying you've got a complex asymmetry and skin excess, I don't think, yes, bring it on. I think go back and see your original surgeon because it's going to cost a lot of money. Obviously, I'm going to charge you full price, whereas your original surgeon would, potentially not do that. But I understand sometimes you lose confidence in the original surgeon. That's why it's important to choose your original surgeon well. But we all have problems. So maybe you're welcome to come and see me if you want, or one of the doctors at the clinic, and we will give you as good advice as we can. But we're not a clinic that specializes in revision gynecomastia, complex asymmetry, and skin excess. Maybe not for you. Maybe you look for a clinic that does specialize in that. I don't know of any off the top of my head. There might be someone out there. So good luck is the answer to that. Areola reduction. I understand you use a certain type of suture to reduce the risk of areola stretching back. I wonder if you know what is the risk of it stretching back. If it does stretch, will it be just a little or back to its original size or more? Cut off the end of the thing there. So that's correct. I use a permanent suture, permanent purse string suture, wagon wheels suture, great technique. I think I saw Paul Harris doing it. Thank you, Paul, for that. And I find that good. Permanent suture, so that reduces the risk of stretching. I wonder if you know what is the risk of it stretching. I have had it stretch before. I can think of it once. So, it's not kind of scientific that, but it's probably going to be like less than 1 in less than 1 in 20, less than 5%, 4%, 3%, I don't know. But it's not a high risk, but it can happen. If the knot fails or if there's a problem with the suture, then it could stretch again. So it's not a sort of zero risk of it stretching. There is a risk of it stretching. It's just less likely to stretch than if you're using a dissolvable suture. If it does stretch, will it be little or back to its original size or more? Yeah, it won't be more than its original size. In fact, it probably won't be back to its original size when there is a problem with a recurrence of an areola reduction. It just stretches out a bit, so it's asymmetrical with the other side. So it's pretty much always one side that recurs, and so it will be asymmetrical with the other side. It's unlikely to go back to its original size because obviously some areola skin's been removed when you're doing an areola reduction, so it's not going to stretch back to its original size, but it might stretch back to bigger than what you would like. And particularly if it's happened on one side, so you've got one side that you're happy with and one side that's bigger, that's the problem when you get a recurrence. It's the asymmetry between the two areolas rather than the fact that it's going back to its original size. So as I say, even if you get a recurrence, it's probably going to be better than what you had preoperatively, but preoperatively you were symmetrical or probably more symmetrical, so you normally do need to do some kind of revision if one side stretches out to try and bring it back into the fold, well, into the line with the other side. Do we offer B-Lite implants? Well, I always say we can offer any implants that are available in to get hold of, and B-Lite implants are available to get hold of. If you don't know what B-Lite implants are, they're a light, as the term. I don't know about the B bit, but they're light. They're light, as in not as heavy as normal implants. So that is good, and I think light implants is a good thing. So I am behind the concept of B-Lite implants 100%. So I normally say we can get any implants. The hospital can get them, and the hospital can get them. Having said that, I don't use B-Lite implants. I used a set of B-Lite implants many years ago, and I had a problem. And I know it's a sample size of 1, but I think sometimes in surgery, particularly, maybe not in medicine, but in surgery, we're a bit like, oh, that happened, so I'm not doing that again. Whereas it might not happen. That might not be a scientific way of doing things, but that's what it is. So I do not use them. The other reason I don't use them is because I think they really come into their own for big implants. So obviously big implants, a heavy implant can be a problem. It stretches the skin and can cause an issue. So I think B-Lites really come into their own for bigger sizes, and I tend not to use bigger sizes. I tend to use smaller sizes, 200-300 cc. Now if you're getting up to 600-800 cc, then a B-Lite is going to be really come in a lot more useful than at sort of 200-300 cc. So and they're very expensive. B-Lites are very expensive. So I don't use them, but for the reason that I had a problem with one set many years ago, and also for the reason that I don't tend to use big implants. But as I say, I think the concept is good, and I think now they've got a polyurethane foam coated B-Lite, which I think could address the problem and could be really good. But it's just that I just don't. So I think a polyurethane B-Lite might be a really good thing. But I have kind of, not just the problem when you get to a certain stage is you kind of, well, I don't know.